very good evening and warm welcome to all my young doctors. So today we are here with our PSM questions, and I know you all are working very hard for your upcoming examination. 19 days to go for our NEET PG exam and 32 days for our FMGE exam. And you all are moving with a single goal to get success in your upcoming examination. As we all know that there are 3 pillars or 3P required for your success. You are having a passion to become a good doctor in future, and continuously you are working hard, improving your mistakes. So persistence, and it is not a journey of overnight. You are having patience, you are working very hard for quite long. So we know that if a table is having 3 legs, sometimes that is unstable. So I'm putting the 4th P, a 4th pillar for the success, and that is your PSM subject. So now we are having 4 pillars, 4 P's for our success. That is passion, persistence, patience, and PSM. Because this is the subject which is going to help you in getting good marks in your upcoming examination and to achieve your goal, that is to get success in your upcoming examination. So in this journey, today we are here with 25 most important PSM clinical questions from commonly asked topics that are definitely going to help you in getting good score in your upcoming examination. So without wasting time, so let's begin our journey. Yes, beta. Very good evening to all. Very good evening. So here comes your first question. Read the question carefully. Try to get the keyword. Don't be in a hurry. Try to get the keyword, because question looking like maybe very simple, but yes, the choices are little bit twisted, tricky. So read the question very carefully and try to answer, okay? So here comes your first question, and that is, you are a newly transferred as Chief Medical Officer of newly formed district in Uttar Pradesh. You decided to do ELISA test for HIV in all migrant laborers, truck drivers, and injectable drug users of that area. Level of prevention is. Okay, so I'm waiting for your response. So here, as we all know, that what we are trying to do here is, yes, the first answer I got is the Kunj Prajapati. Yes, very, very good. It is secondary level prevention. So everybody is giving me correct answer. So try to understand that why this is a secondary level prevention. The first of all, we are saying that we are doing ELISA test. So ELISA test for the HIV in migrant laborers, truck drivers, and the injectable drug users. These are high-risk cases. And in those high-risk cases, we are putting this ELISA as a screening test for early detection. So every one of you is giving me correct answer. Now, Shivaram Beta, it is not an option B. It is not a primary specific. It is your screening sort of. So it is secondary level of prevention. So I have a quick revision what our different levels of preventions are. So whenever we are doing any activity to avoid this agent or risk factor in the community. So we were talking about that if we are focusing on avoiding the agent or risk factor, it is our level number 1, that is primordial level prevention. If in the presence of agent or the risk factor, we are trying to avoid the disease, just putting this barrier, so we'll not have the disease, it is our primary level prevention, level number 2. And if it is for the individual person, it is the specific, and if it is for whole community, it is your health promotion. If we are trying to early detect a disease, that is your secondary level prevention, level number 3 is in the early pathogenic phase. And if you are trying to manage the complications to avoid or to manage disability, it is our tertiary level prevention. So in the exam, usually they are giving you the different type of questions. Every time they are giving you a different example. Okay, so we should be clear with our concept, and we'll try to see that whether the risk factor is absent or not. So if risk factor is absent, then it is your primordial level prevention. If in the presence of the risk factor, if the disease is absent, usually it is either the primordial or primary level prevention, and usually the disease is present in secondary level prevention, where we are doing an early detection. But if it is a screening sort of thing, sometimes the disease may be absent also, and complications are usually present in the tertiary level prevention. Disability may or may not be there. So in this way, we can easily identify our levels of prevention. Now coming to our next question. Mother brings her 6-month baby for the first time to immunization clinic, as your multipurpose worker male decided to give some vaccine orally. What is that vaccine? So here, what we are supposed to do, that first of all, we have to see that we are trying to give vaccine by which route? We are trying to give vaccine by oral route. And the second catch here is that the baby is 6-month-old baby, and baby is being brought for the first time to immunization clinic. Now we know that OPV, yes, the answer, it is coming as A also, B also, C also. So let us see. Now OPV, it is yes given by oral route. Rotavirus is also given by oral route, and vitamin A is also given by oral route. So I'm getting a mixed bag of response, but maximum of you are answering quite right. It is the A. Now why or how? Now we know that OPV, it is started since birth, and the birth dose, that is 0 dose, OPV 0 dose, can be given till 15 days. But routine OPV, what we are starting at 6 weeks, so 6, 10 and 14, we are giving first, second and third dose. And the last we can give as a delayed immunization up till 5 years. Now coming to rotavirus, it is usually started as 6, 10 and 14 weeks, but the first dose to be given in an age of less than 15 weeks up to 14 weeks, 6 days. It cannot be started beyond that. And here the important catch is that baby is coming for the first time at what age? At the 6th month of the age. Okay. So we cannot start 6 months, roughly it is around 26 weeks. So we cannot start a rotavirus at all, although it is given by oral route. Vitamin A, it is again given by oral route, but it is usually started at 9 months of the age. So the best answer is, that is the correct answer is option number A, that is oral polio vaccine. Now quickly have a look on our immunization schedule, that is universal immunization schedule, and program May, we are following the national immunization schedule. Okay, it was started on 19 November 1985 as a rename of existing the API, that is expanded a program of immunization. And here we are starting our vaccination right at birth, and we are giving the BCG vaccine, the 0 dose of OPV vaccine, and birth dose of the hepatitis B if it is your hospital delivery. But if it is your home delivery, we cannot give the hepatitis B birth dose because it is given by intramuscular route, and we cannot give any injectable vaccine in home delivery. So yes, OPV 0 dose we can give till 15 days, and the BCG is given in the next visit whenever the baby is coming. Then we are starting our routine vaccination at the 6 weeks. So 6, 10 and 14 weeks, we are giving the first, second and the third doses of the pentavalent vaccine, oral polio vaccine and rotavirus vaccine, as well as at the 6 weeks and the 14 weeks, we are giving the first and the second dose of first fraction, second fraction of the IPV, as well as the first and second dose of pneumococcal vaccine. Then we are giving our routine vaccination at 9 completed month, where we are giving the first dose of the measles containing vaccine, the booster of the pneumococcal vaccine, the Japanese encephalitis first dose in endemic areas, then the third fraction of an IPV vaccine, and yes, we are starting the vitamin A. Between the 9 to 12 months, we are giving the first dose and this is 1 lakh international units. And then every 6 months till 5 years, we are giving the dose as 2 lakh international units, provided the baby is growing normally, means after 1 year the baby weight is 8 kgs or more. But at any time the baby is malnourished beyond 1 year, then at that particular time we are giving 1 lakh international unit dose only. So if a baby is growing normally, as prophylaxis we are giving the 9 doses, and the total amount of vitamin A what we are giving is 17 lakh international units. And then we are giving at 1.5 year the booster of the OPV, then the DPT first booster, second dose of measles containing vaccine, and the second dose of Japanese encephalitis. At 5 year we are giving the second booster of the DPT, and the 10 and 16 year we are giving the doses as TD. Remember here the D is small because a smaller amount of diphtheria we are giving, it is not the capital T, capital D. So this is our routine, the immunization schedule of universal immunization program. So we should be very clearly knowing this schedule. And sometimes they can be asking about the site where we are giving these vaccination. So the oral vaccines we are giving as OPV, rotavirus, vitamin A. These are the 3 vaccines of our program, as well as we are giving the live typhoid and the cholera vaccine also via oral route. Now at the left deltoid, we are giving at 6 weeks is very important vaccine is the BCG, and at 9 completed month we are giving the 3rd fraction of IPV in left deltoid. Now in the right deltoid at 6 weeks we are giving the first fraction of the IPV, as well as at 14 weeks we are giving the second fraction of IPV, while at 9 months we are giving the first dose of the measles containing vaccine, and 1.5 year is the second dose of measles containing vaccine. In right thigh usually we are giving pneumococcal vaccine, and the left thigh we are usually giving the T group of the vaccine, that is hepatitis B or the pentavalent vaccine or a DPT vaccine or the TD vaccine. Okay, and always remember, in a baby less than 2 years, if we have to give any intramuscular, we are giving on the middle 1/3 of anterolateral aspect of the thigh. We are not giving in the gluteal area. So sometimes they can be giving this image, putting an arrow that what can be the vaccine which is given by this route. Okay, so this is all about our program of EUIP. Now sometimes they could be asking as an image based question. So whenever there is white dropper, so white dropper is for your OPV, and the pink dropper it is for your rotavirus vaccine. Okay, so by this image also you can identify that what is this vaccine is. And one more point is that this is your vaccine vial monitor sticker, which is going to check for heat damage of the vaccine. Now here there is an inner square which is changing its color. If it is same color or the darker than the outer circle, then it is grade 3 or the grade 4 we have to discard. Now few more points about the vaccination. You have to remember that about the storage of the vaccine, the cold chain, and this is the sticker, the VVM, which is going to check the heat damage of the vaccine, as well as there is another shake test which is used for knowing the heat damage of the vaccine. Then another area from where question is asked is open vial policy. So these are some of the areas from where commonly questions are asked in about in our topic of vaccination. Now coming to the one very, very important point is that life is a journey, and what we are going to achieve in this life, it is the 10% what happens to us. It is the deciding factor, but 90% is how we react to this. Now, if we say that you are appearing in your any of the GT test, you are appearing in your subject test, or you are solving your practice MCQs. Now, suppose if you are making mistake, you are not able to recall. Now, there are the 2 ways to approach to this situation. The approach number 1, that you will be rectifying your mistake. Try to quickly look those topics where you are making mistakes and correcting those mistakes. And the second is that you may be thinking whole day about that why I had made this mistake, why I'm not able to remember, and you will be wasting your whole day. Okay, so which one is better? The approach number 1 is better than approach number 2. So how we react to our situation, that will be our deciding factor for success. So I can say that have a positive attitude. You can make mistakes, but the thing is that how you are correcting those mistakes, how you're learning from those mistakes, and how you're making your further strategy will be your deciding factor of success in future. Now coming to our next question, new screening test with 90% sensitivity and 80% specificity is applied on a population where prevalence of anemia is now changed from 20% to 10%. What will be effect on positive predictive value and negative predictive value? Okay, so what we are doing here is that we are changing prevalence from 20% to 10%. It means what is happening? Prevalence is reducing. This is one thing. Now, second thing is that test is same, which is having 90% sensitivity and 80% specificity. So if we are using the same test in the different situations where prevalence is changing, okay, so sensitivity and specificity will remain the same, then what will be changing is predictive value. Okay, so positive and negative predictive value, it depends upon prevalence. Okay, so we know that positive predictive value, it is directly proportional to our disease prevalence, and negative predictive value, it is inversely proportional to our disease prevalence. Now here prevalence is what? Reduced. So if prevalence is reduced, so what will happen to the positive predictive value? It will also decrease. And if a prevalence is reduced, what will happen to the negative predictive value? It will increase. Okay. So yes, many of you are answering quite correct that positive predictive value will decrease and negative will increase. Now, beta ji, those who are answering option number C, now see carefully that here the prevalence is not increasing, here the prevalence is decreasing. So your answering for this is option C, as if prevalence is increasing. So if prevalence is increasing, then your positive predictive value will increase and the negative will decrease. But here it is opposite is happening. So see the question very carefully. They had changed from 20% to 10%. If I simply write that they had reduced the prevalence, you could have very well answered. So this is a tricky catch, that here it is reduced from 20% to 10%. It means your positive predictive value will decrease and negative predictive value will increase. Okay, so yes, the correct answer for this question is option number D. Now quickly have a look that what is the relationship between the different parameters, and here very commonly asked this relationship between the prevalence and the predictive value. Now prevalence is directly proportional to the positive predictive value and it is inversely proportional to negative predictive value. Okay, and we should be knowing here simultaneously the four definitions which are very commonly asked from us in the examination, as well as their formulas also. So sensitivity means ability of a test to correctly detect a disease. That means a true positivity is a sensitivity. What is specificity is ability of a test to correctly exclude a disease. That is true negativity. And what is a positive predictive value means ability of the test to detect a disease in a positive test results. And what is negative predictive value is ability of a test to exclude the disease in a negative test result cases. And we should be knowing the formulas also. And sensitivity, it is true positive upon true positive plus false negative, and specificity is true negative upon false positive plus true negative. Now we had discussed this so many times that how smartly you have to remember. You have to remember only the 2 points. One is that sensitivity is true positivity and the denominator is opposite. So true positive plus false negative, it is your sensitivity. Now if it is all positive, numerator is true positive and the denominator is all positive, true positive plus false positive, it is your positive predictive value. Now what is specificity? It is true negative as a numerator and the denominator is false positive opposite plus true negative, and if it is all negative, that is true negative via false negative plus true negative, it is your negative predictive value. But always remember that there is no false positive or the false negative in the numerator. It is always a true parameter. Then we should be also knowing about commonly used screening test about the two very important cancers, and one is cervix cancer. So the best screening test for the cervix cancer is what? It is pap smear, but only problem is that it is able to perform from district hospital onwards because we require expert cytologists. So if they ask what is the cost effective or what is the test we can do at periphery, it is the VIA is preferred over the villi, that is visual inspection after applying the acetic acid, where the aceto-white patch is suspicious, while in the villi, that is visual inspection after the Lugol's iodine, where the colorless patch is suspicious, and we are referring these patients to a hair center, and the confirmation is done by the colposcopy guided biopsy. Now the second important disease or the cancer is breast cancer, and in that, if I say that cost effective screening test is the self-breast examination, and the preferred time is post-menstrual. If I say the best screening test, it depends upon the age. 40 plus, it is supposed to be mammography, and less than 40, the best is MRI, but preferred is it is your breast ultrasound, because MRI facilities are not available everywhere. And yes, it is the biopsy, and that is the final diagnostic thing. So these are some of the important points which are being asked from this topic of screening. Now coming to our next question, total number of girl children remaining alive till their own reproduction born to a woman in her entire reproduction is the definition of one demographic parameter. All are correct about this except. All are correct about this except. So here, the first of all, what is this demographic parameter they are talking about? Total number of girl children remaining alive till their own reproduction. So they are talking about one parameter, that is net reproduction rate. Now, is the definition of the one demographic parameter, all are correct about this except. So beta G's, those who are answering option number A, please see carefully. They are asking us that all are correct about this except. Okay, so yes, this is an NRR, and what is GRR? It is the total girl children born alive to a woman in her entire reproduction. They are not concerned about whether they are reaching till the reproduction or not. Most important vital demographic indicator is also NRR. So this is also about the same indicator, and only demographic vital fertility indicator which includes the mortality, it is also NRR. So here option number A is true for this statement. Option number C is also important, and option number D is also important. So here which is incorrect about this is GRR, and that is the answer. So very important message with this is that although you had read the first choice, that is NRR, you are right, but never ever do this mistake that click your answer without reading rest of the choices. Okay, you have to read the rest of the choices also, because in the exam you have to get the best possible answer from the correct choices. Okay, so here that is not correct about this is gross reproduction rate. So here GRR, it is the correct answer. So those who are answering option number B, it's a big clap for them, because they are getting this hint and they are not going to trap themselves in the trap, and yes, they are marking correct answer. Okay, now quickly revise what are the various demographic indicators. Very important area, and from here a question are very commonly asked. So you are having the two major group of the indicators. One is the vital indicator, another is population indicators. Now four very important vital indicators are commonly asked, although there are so many. So what is general fertility rate? It's a total live births per 1,000 reproductive female, that is general fertility rate. What is TFR? Is the total children born alive to a lady in her entire reproduction. It is also a completed family size. What is GRR? That is gross reproduction rate. You can remember as the T for total and the G for girl. So total number of the girl children born alive to a woman in her entire reproduction. And what is the net reproduction? It is like a business if we consider reproduction as. So the total number of the girl children remaining alive till their future reproduction, for their future motherhood, to a woman in her entire reproduction is net reproduction rate. And what are the various population indicators? One is sex ratio. It is number of female per thousand male. If they didn't mention anything, it is the sex ratio at birth. But if they say the child sex ratio, it is within first 0 to 6 years. That is number of the female per thousand male. Okay. So if it is 1000 means it is equal. If it is more than 1000, it is favorable for girls. If it is less than 1000, it is unfavorable. What is dependency ratio? Now, dependency ratio means that how many are non-working dependent on working, and what is the non-working population, that is numerator is less than 15 years and more than 65 years. And what is the denominator is the working population, that is between 15 to 65 years. And what is literacy rate is number of the literate person per 100. Very important is not the total population, it is 7 years and above. That is what is literacy rate. So sometimes they can ask a small numerical, keeping the definition in mind, and always remember in PSM very small numerical can be created based on the definition. So if you know the definition, then very easily you can answer these type of questions. So these are about our demographic indicators. Now, as we are completing our journey towards success, we need strength, because there are times, sometimes we might feel low. And who is giving me strength? So these are the 5 very, very important sources of my strength. Now, people who says, I couldn't, I have to show them that yes, I can do it. The people who look down on me, I can show them that yes, I will be on the top one day, and then you will see. Now, people who doubted me, I have to show them that yes, I'm a strong person, I'm a winner, I can do it. The people who told me that it was impossible for you, I have to show them that yes, it is possible for me. And people who laughed at me, at my mistakes, and I have to work silently, then only my success should speak in community. So these are my 5 sources of my strength, and keep these sources alive around you. Don't be afraid of these sources. Don't be afraid of listening all these negative things. Now you have to improve yourself from your mistakes, and one day you have to just show them that yes, I can do miracles. I am having power. I can do everything in my life. Okay. Now coming to our next area, from here also very commonly question is asked, that is phases of demographic cycle. Now phase of demographic cycle where both birth rate and death rate are on decline mode, but population is increasing because birth rate is more than death rate. Now what is that phase is? So first of all, we have to find out what that phase is, where birth rate and the death rate both are declining, but the birth rate is more than death rate, and that's why population is increasing. Now if we quickly revise our phases of demographic cycle, that the first phase is the high stationary phase, where the population is very high birth rate, very high death rate, but population is stationary. Then phase 2 is an early expansion. The birth rate is very high and death starts declining. So population is increasing at a very fast rate. So again, it is not a phase 2. Then what is a phase 3? That is phase 3. It is that birth rate is also declining, the death is also declining, but birth rate is more than death rate. And you all are answering very correctly without making a single mistake. And this is our phase number 3, that is late expansion phase. Now, why I had kept this choices, because sometimes you may be coming to that it is a late expansion phase. You might be having the confusion that whether this is a phase number 2 the phase number 3, because here we are supposed to remember the phase number as well as what that phase is. So here it is not an early expansion, that is clear. Now late expansion, it is phase number 3. Okay, so those who are answering is phase number 2, no, it is not, and it is your phase number 3, that is late expansion phase. Now quickly have a look on the demographic cycle or the transition. Again, this is a very, very important chart also, and many mixed match questions, so the mixed bag of the questions are asked from this. So this is your phase 1, that is high stationary with a high birth rate and high death rate, but still population is stationary. Then comes the early expansion phase, that is birth rate is high, but the death starts declining with the medical services, and here the population suddenly starts increasing. So it starts increasing at the beginning of the phase 2, and it is maximum at the demographic gap is maximum, that is gap between the birth rate and the death rate at the end of the phase 2. Okay, that is early expansion phase. So population is increasing but at a very fast rate. And then came the late expanding phase. The birth rate starts declining with use of contraceptives. Death continues to decline with development of the medical services, and still the birth rate is more than the death rate. So population is increasing but at a slow rate, and this is important because we, India, in this phase of late expansion phase or phase 3, then comes the low stationary, the birth rate is low and the death rate is low, but they are almost equal, so population is stationary. And then coming to our last phase, that is the reversal phase. Nobody wants to have kids. They can have pets, they can have dogs, they can have cats, but they don't want to take responsibility of bringing up the kids. So birth rate is 0, but nobody can stop natural deaths. So population is getting reversed. So it is again not supporting our ecosystem. So this is your reversal phase or phase 5. So we are the India, it is in which phase? It is in the phase 3 of the demographic cycle, that is the late expansion phase. So demographic or transition phases, demographic cycle is again a very, very important area from where questions are commonly asked. Coming to our next question, correct about given contraceptive. So first of all, we have to see that what contraceptive they had given. Some structure like a T with the thread and copper on the horizontal arm and the vertical arm. So this is none other than our copper T. So this is a what? It is your copper T 380A. So the question is, what is correct about this contraceptive? Shelf life is 10 years. Yes, this is a true statement. Most common problem is irregular menses. Yes, it is a true statement, but demands immediate removal of the device. No, it doesn't demand the immediate removal of the device. We have to give assurance for at least 3 months. Okay, we might be giving iron folic acid, so this is your false statement. Past history of PID is not an absolute contraindication. Yes, it is a true statement. Now, we say it is a relative contraindication, so it is a true statement. And removed by laparoscopy if it is found near ovaries, means outside uterus at any time. So it is also your true statement. So option number 1, 3 and 4, it is correct. And a big clap for all of you that you are answering correctly. That is the option number C, that is 1, 3 and 4. So 1, 3 and 4, it is correct answer. So we should be knowing important points about the IUCDs, that is intrauterine contraceptive device. It is a very, very important method of contraception, that is temporary method of contraception. These are the 3 important devices which are commonly asked as an image-based question, and how you can identify everywhere there is thread hanging below. So it means it is your intrauterine contraceptive devices, because what is the purpose of this thread is that when patient is coming for follow-up, you can say, okay, thread is seen, it means device is in place. Second is, if you want to remove the device, you can simply pull the thread and take device out. Now, they could be the generations of the devices. If copper is present, this is the second generation device. And if you are seeing this is bulge in the longitudinal arm, and this is looking like as a capsule which is containing hormone, and usually the progesterone, levonorgestrel is there. So this is the third generation device. Now, if it is a T-like structure, this device is your copper T380A. And if it is having the shape like the uterine cavity, this is your multi-load, and commonly it is we are using is 375. And the bulge or the hormonal device, it is that is LNG20, and brand name of this is Mirena. Now here 2-3 more questions are very commonly asked is what is shelf life? Now shelf life of Mirena is, it is 7 to 10 years. So minimum it is acting for 7 years as per PARC clearly mentions. Then copper T380A, it is for 10 years, and multi-load 375, it is for 5 years. Now what these numbers are representing, these are the surface area of copper in square millimeter. Now here very commonly asked question is that how much of the hormone is released per day? It is 20 microgram of levonorgestrel. Then very commonly they are asking about the contraindications for putting the device, and when we are putting the device, and for what or which type of individuals it is supposed to be a best method of contraception. Now copper devices or ICDs are supposed to be the best for birth spacing, means after a person has, the lady has delivered the first baby, and then if she wants a gap between the next pregnancy, then for the birth spacing, these are supposed to be the best method of contraception. What are the absolute contraindications are that if there is existing PID, or if there is a undiagnosed bleeding per vagina, suspected pregnancy, or if it is a copper device, then Wilson disease, it is an absolutely contraindicated, or there is a big size fibroid or any uterine anomalies which is distorting the cavity, like a septate uterus or a unicornate uterus or the bicornate uterus, where bicornate uterus where the cavity is distorted, then it is difficult to insert the device. While LNG or the progesterone devices, they are contraindicated if the person is having family history of breast cancer. Now always remember that this Mirena, it may be a therapeutic if it is a small fibroid, or if it is their menorrhagia or AUB, or if there is a endometriosis, then it can be therapeutic. But if it is a big fibroid which is distorting the cavity, then it is having an absolute contraindication. And these copper devices, the non-contraceptive advantage could be that if we are doing an adhesiolysis of a HMN syndrome, so post-adhesiolysis, we can put this device to keep the walls of uterus separated to prevent the re-adhesion formation. And what are the, I could say, the relative contraindication? The relative contraindication is that the patient is already having anemia, or if a patient is having the past history of PID, or if she is primigravida, or if there is history of multiple sexual partners, then it is your relative contraindications. Now, most common problem we can have with this IUCD is what? It is irregular menstrual periods, but body takes around 3 months time to adjust to this, and during this time we have to give reassurance, and we will be supplementing iron folic acid tablets. But if a patient is coming with severe pain in abdomen, any symptoms of existing pelvic inflammation, the purulent discharge, in that case we have to immediately remove the device and giving antibiotics. There could be displacement of the perforation. If it is inside the uterus, we can remove with hysteroscopy, or if it is outside the uterus, then we have to remove with laparoscopy. And the best time is post-menstrual, but preferred is the postpartum, just after delivery, within 48 hours of the delivery, we are putting this device. So these are very, very important points about our this contraceptive, that is IUCD. As the journey what you are following is quite long, you are working very hard, you are human beings, you may get tired so many times. But if you are chasing your dreams, then there is no scope to stop. how much you are tired, you can take a rest for some time, for a few minutes, then again you have to continue, because your dreams are big to chase, which are not letting you to stop. You have to stay strong. You have to bear all these hurdles, obstacles, and ultimately you have to reach to your end point, and the end point is to get success in your upcoming examination. Another very common area from where question is asked is another type of temporary contraceptives, and that is pills. So all are incorrect about Mala D except. So read the question very carefully. All are incorrect about Mala D except. Now Mala D, it is having the similar formulation as Mala N. Only difference is Mala N is available free of the cost in the national health centers, and Mala D we have to purchase at a cost of around 3 to 5 rupees from medical store. Now ovulation inhibition is a mechanism of action. It is true statement. It is true statement because it is acting as ovulation inhibition. Can be advised to lactating women just after delivery. No, it is a false statement or incorrect statement. It cannot be advised because Mala D, it is inhibiting or suppressing lactation. Increase risk of deep vein thrombosis. Yes, it is increasing the risk of deep vein thrombosis, but it is not increasing the risk of ovarian cancer, it is decreasing. So it is also false statement. Now contain 30 milligram of estrogen and 150 microgram of progesterone. Now this is also a wrong statement because it is not 30 milligram beta, it is your 30 microgram. It is 30 microgram of the estrogen and 150 microgram of progesterone. Now, I could see that you all had got the hint. You are changing your answer from B to A. Okay, you change your answer from B to A because earlier you were marking that answer B. Okay, so please listen carefully that they are asking what is correct statement. All are incorrect about the Mala D except means they are asking that what is the true statement. So correct statement, and that is the answer to this is it is ovulation inhibition as a mechanism of action. So yes, this is a true statement. The rest all are incorrect statement. So again, this is a very, very important contraceptive, that is Mala N or Mala D. As I say, Mala N is freely available. Now it is having the 21 active pills and 7 inactive pills or the iron pills. Okay. Now this is to be started from the day 3 to day 5 of cycle. Now each single tablet of this Mala N, it is containing the 30 microgram of ethinyl estradiol and 150 microgram of levonorgestrel. So see unit very, very carefully. And daily lady has to take 1 tablet, and when these active tablets are finished, then she is taking these iron tablets, and during this patient is having withdrawal bleeding. Okay, so the composition of this iron tablet each is containing the 19.5 milligram of elemental iron equivalent to the 60 milligram of salt, that is ferrous fumarate. Now no confusion, now in the adult iron folic acid tablet what we are giving as a prophylaxis in pregnancy or more than 10 years individual, children and the reproductive female, it is containing the 60 milligram of elemental iron. Mechanism of action is ovulation inhibition. And very, very important question that is asked is what cancers are reduced and what cancers are increased with this. Now cancers which are reduced is ovarian cancer and the endometrial cancer, and the cancers possibility which are increased is breast cancer. Then we are having the cervix cancer and benign hepatocellular adenomas. Okay, and mechanism of action is ovulation inhibition. And very important is that where it is advised, it is to delay the first pregnancy in recently married couple, where we cannot usually put IUCDs, where condoms are not very effective because they are having high failure rate. So here the Mala N is preferred, or any of the OCPs it is preferred, because it is having quite good efficacy in the low Pearl index. Okay, so these are some of the important points about these hormonal preparations. We are having the non-hormonal oral pills also, which are available in the market as Saheli tablets, or we are having in the national program as Chaya tablet or the Centroman tablets. These are non-hormonal tablets which can be taken orally, so they are not having the side effects of the estrogen and progesterone what we are having with Mala N. And very important side effect is there is a risk of development of deep vein thrombosis and the risk of development of cancers. What we had seen is the breast cancer and the cervix cancer. Another very, very important area is maternal mortality, from where questions are commonly asked. As per survey, in year 2023 in Bihar, per 1 lakh live births, maternal deaths are as follows. So see carefully, per 1 lakh live births, maternal deaths are as follows. 20 deaths because of APH, that is antepartum hemorrhage placenta previa, 10 deaths because of eclampsia, 5 deaths because of road accidents, 5 is due to rupture uterus, and 50 is because of PPH. For calculation of MMR, maternal deaths calculated as. Now, as I say that in community medicine, very easily a small definition is converted into numerical. Now, what is maternal mortality ratio? Maternal death very commonly means it is a maternal mortality ratio. Now, maternal mortality ratio is number of the maternal deaths per 1 lakh live births. Now, the big question, which death you will be including as maternal death? Any death which is happening, which is related to pregnancy, or it is aggravated by the pregnancy, but it is not due to accidental or the incidental causes, one thing. Starting from the pregnancy till end of the puerperal phase, that is 42 days after delivery. So let us see that what are the deaths related to pregnancy. Is APH related to pregnancy? Placenta previa cannot happen other than pregnancy. So yes, this is related to pregnancy. Eclampsia, yes, it is only related to pregnancy. Road accidents, no. So I will be excluding this road accident. Now, rupture uterus, yes, it is related with pregnancy delivery, and PPH, yes, it is related to that. So we are having the total deaths as 20, 10, 30, 50, that is 80, and 5 is 85. So my maternal deaths are 85, not 90. This is my first thing. Now, they had already mentioned me that it is per 1 lakh live births, so no rocket science. I know maternal deaths per 1 lakh live births is my MMR, so my answer is 85. So most of you are answering correct, that is option number B. Now, those who are answering option number A, now be very careful that we have to exclude this road accidental deaths. Okay, this is one thing. Now, second thing is beta, those who are answering as 0.85, okay, because 0.85 you will be taking if you are converting this into per 1000, okay. It is not your per 1000, they had already mentioned it is per 1 lakh, okay. So those who are answering as option D, it is again a wrong statement, because you are counting this as per 1000. Always remember the maternal mortality, it is calculated as per 1 lakh. So here the correct answer is, it is 85. So this is again a very, very important area. So quickly have a recap of this topic. So they ask the definition. So what is maternal mortality? It is a ratio, maternal deaths per 1 lakh live births. Okay. Now, what is maternal mortality rate? It is a maternal death per 1 lakh reproductive female is rate, but very commonly they are asking or they want to know from us is ratio. It is your maternal deaths per 1 lakh live births, because ratio means we are comparing two different things. We had already talked about the definition. It is any death either due to pregnancy or it is aggravated not due to accidental or the incidental causes. The duration is from the point of the conception till 42 days after the delivery. So in the calculation, we are including all the three phases, antenatal, natal and the postnatal. And the most common period where we are having the death is postnatal, and the most common cause is hemorrhage, and again the PPH is the most common cause of the maternal deaths, and indirect cause it is anemia. Okay, and the best thing is that if we have to improve the maternal mortalities, we should be knowing what is the cause of the death. And as many deaths are happening in periphery, and by the time the team is reaching there, already the cremation of body has been done, so body is not available for autopsy. So the best way is to do the verbal autopsy to know cause of the death. That is what is called as rhyme method. Okay, and here if I give you one example that how you can be identifying cause of the death. Suppose a delivery has happened and the patient dies, and mother was there at the time of the delivery, and the team of health workers or the team of experts has gone to their house and they had interacted with mother. So mother says that, doctor, my daughter was having the very healthy antenatal period. This was her second pregnancy. The first baby she delivered normally 3 years back. The antenatal period was smooth. She had a spontaneous onset of labor pains, and delivery was very smooth. And see how this beautiful baby delivered. And there was a normal delivery, and suddenly after the delivery, डॉक्टर साहब इतना खून बहा कि पूरी बाल्टी भर गई, और जो नर्स अटेंड कर रही थी उसने कहा बच्चेदानी का गोला नहीं बना. What it means that there was a heavy bleeding after the delivery, and usually after delivery there is contraction of uterus, and this contracted uterus feels like as a very hard ball, and this is just above the pubic symphysis, and it means that uterus was not contracting, so hard ball was not formed. And what is the cause? It is an atonic PPH. So very easily you can come to know that what was the cause of the death, and until unless we are not knowing the cause of the death, we cannot make the policies to reduce these mortalities. Okay, and the current value of MMR of India is 97 per 1 lakh live births. Now our goal was, it is not redefined here, it was to get this MMR of 100 to be achieved by 2020. We had achieved in 2022 as 97, and it is a average. Now we are trying that in each and every district this should be 100, because now in some districts it is less than 100, but in some other districts it is high up, so also up to 130, 140 also. And the global goal is, that is as per the sustainable developmental goals, that MMR should be brought down to less than 70 by 2030. So these are some of the important points about maternal mortality and how we can improve or reduce this maternal mortality by giving the good antenatal, natal and the postnatal care. And the minimum antenatal visits should be 4, minimum postnatal visit should be 3, and we have to conduct the delivery by a trained personnel, expert personnel, keeping 5 clean methods. And in our periphery, the most important worker which is conducting the delivery is multi-purpose worker female, and the lowest institution where we can have this delivery is sub-center. Okay, so these are some of the important points we should be knowing about this topic. Now, another very, very important point is, like कहते हैं ना कि अगर आपको युद्ध जीतना है तो आपकी स्किल तो काम आती है, लेकिन वो दिमाग से भी जीता जाता है. जब तक आपने अपने दिमाग में नहीं बैठा लिया कि मुझे ये युद्ध जीतना है, मैं ये युद्ध जीत सकता हूं, आप नहीं जीतोगे, चाहे आप कितने भी एक्सपर्ट वॉरियर हो. So, very important point is that mindset is a determining factor whether you are going to get success or not. So, you have to win your mind that yes, I'm capable of getting success. I'm working quite hard, and definitely I will be getting success, whatever will happen. So until unless you are keeping this positive thought in your mind, whatever you are doing, studying, always you are in negativity, you are doubting yourself, you are doubting your capacity, capability. So you have to first prepare your brain that yes, I'm working so hard, I'm having so much of knowledge that very easily I can get success in my upcoming examination. Okay? Next question. A medical officer was conducting delivery at PSC. Everything was going normal. Fetal heart rate was 144 per minute, but baby had difficult removal and baby born as asphyxiated got admitted in ICU, where baby died on day 10 of his life. That is very important. So this mortality will be included in calculation of. This mortality will be included in calculation of. Now, first of all, we should be knowing that what are these periods are. Now, late mortality, neonatal mortality, it means the death between 1 week to 1 month. Death between 1 week to 1 month is late neonatal mortality. What is your post-neonatal mortality? The death between 1 month till 1 year. It is your post-neonatal mortality. Now, what is perinatal mortality? It is death from 28 weeks of pregnancy till 7 days after delivery. It is your perinatal period. So where the death is happening? The death is happening on 10th day of the life. So it is coming in this group as late neonatal mortality. Okay. Now if they say the death is coming at the 2nd month, then it will be coming in post-neonatal mortality. Now, if they say the death is coming on the 3rd day of life, then it will be coming in perinatal mortality. Okay? So, here the death is coming on the 10th day of the life. So, this will be in late neonatal mortality. So, big clap to those who are answering as option number A. It is correct answer. So quickly have a look on these mortalities, because here very commonly question is asked, or sometimes they can ask numerical also. So any death which is happening from the birth till 5 year, it is your under 5 mortality rate. Any death from the birth till 1 year, it is your infant mortality rate. Now from the birth till 1 month, it is your neonatal mortality rate, and from the 1 month till 1 year, it is a post-neonatal. If you dissect the words post-neonatal, neonate means it's a baby for 1 month, and post-neonate means after 1 month till 1 year. So post-neonate and neonate includes as the infant mortality rate. Now neonate is further divided into early neonate means first 1 week, and the late neonate means 1 week till 1 month. And the perinatal mortality, which is supposed to be the best indicator of the MCH care, is from 28 weeks till birth, means any of the intrauterine death, during delivery any of the perinatal death, and first 1 week after the delivery of this baby, it is included in perinatal mortality rate. So early neonatal mortality is a part of perinatal mortality rate, and all these mortalities are expressed as per 1,000 libus. Now, best indicator of the health status of a country is infant mortality rate, and the best indicator of the MCH care is perinatal mortality rate. So remember these mortalities, and we know that we can avoid or we can reduce these mortalities by taking certain actions. We are promoting for breastfeeding. We are giving the immunization as per the schedule to our babies. We are doing a good growth monitoring, and growth monitoring is usually done by Anganwadi workers, and we are doing the school health means till 6 years we are taking care of these kids in this ICDS centers, and after 6 years we are dealing these kids till 18 years in the school under school health. So by taking proper guidelines, doing their examination, early detecting the problems, managing those conditions, we can reduce these mortality. So again, this is a very important area from where commonly questions are asked. In ICDS centers, Anganwadi workers are posted covering 1 per 800 population in plain area. These centers are mainly concerned with well-being of children of 0 to 6 years. Growth monitoring is a very important function of these centers. According to ICDS growth charts, what is interpretation of given observation? Now see the observation very carefully. Now weight for age, it is minus 2.5 SD. Weight for height, it is minus 2.4 SD. Height for age is minus 1.8 SD. What is your interpretation? What is your interpretation? Okay, I'm getting the answer as acute malnutrition. Now let us see whether it is correct or not. Here actually it is a little bit integration between the growth chart and your biostatistics. Okay, now we know in the biostatistics the basic fundamental is any value within plus minus of the 2 standard deviation is considered as normal. Now here the weight for age, it is minus 2.5 towards the lower side. Below minus 2 means this is what? Abnormal. So means there is low weight for age, that is abnormal. And we know that low weight for age is suggestive of what? It is suggestive of both acute plus chronic malnutrition. Weight for height, again it is below the limit, minus 2.4 SD. So there is low weight for height, which is suggestive of, it is suggestive of acute malnutrition. But height for age, it is within the limit, minus 1.5 SD. So it is suggestive of chronic malnutrition, but it is in the normal limit. So only parameter which is affected is the weight for age is low, which is of both acute and chronic, but another very specific parameter of acute is low weight for height, that is acute malnutrition, or it is wasting also. So here the best correct answer is option number A, and yes, a big clap for all of you. You are answering very correct answer, that is it is acute malnutrition. Now just see carefully, if I say that instead of this minus 1.8, if I say this is minus 2.8 SD, and it means there is low height for age also, in that condition my answer will be changing to both, that is acute and chronic malnutrition. Okay, so this is very, very important growth chart, and what we are using in the ICDS centers, ICDS growth charts, or it is MGRS growth charts are there. And here we are having 3 lines. Okay, so we should be knowing that what these lines are representing. Now we are not going towards an upper side, what sometimes we are getting the chart in urban areas with private practitioners, because we are mainly concerned with the lower weight or the lower side of the babies. Now here we are having the 3 lines. This is the first line, which is representing about the 50th percentile. So it is representing the 50th percentile. Then we are having the second line, and this second line, it is representing the minus 2 SD, and the third line, it is representing the minus 3 SD. Okay, any value between the first and the second line green zone, it is normal because our lower limit is minus 2 SD. Now any value between the second and the third line is mild to moderate undernutrition, and value in the red zone, that is below the third line, it is your severe degree of undernutrition. Now this is how the Anganwadi workers, they can detect the growth monitoring. They are doing growth monitoring, and they are detecting that some problem is there with the baby, and they can refer the baby to higher centers for early diagnosis of the underlying problem and the treatment so we can reduce mortalities. So Anganwadi centers are very, very important centers, especially in the village. So village mein the only center where health worker is working, it is the ICDS centers, because other workers like an ASHA worker, the TBAs, or village health guide, they are working from their house. And here the main beneficiaries are children from 0 to 6 years, and their main function of these Anganwadi workers are that they are doing growth monitoring, they are giving vaccination to the children, and then they are also distributing midday meal as well as giving them non-formal school education and the health education to the mother and other adolescent girls and reproductive female. So the main beneficiaries are 0 to 6 year, because children are not going alone, so they're the mothers, and we can remember as the bodyguards. And who are the bodyguards? The adolescent girls and the other reproductive female of that area. So these are the beneficiaries of these ICDS centers. Now we know that this process is quite long. This journey is little bit long, and we are working very hard. Now, whenever we are working, always remember that never go in overconfidence also, because sometimes when you are doing any practice session, you are trying to answer all the questions very correctly, and you are getting very good score, and you say, okay, this subject is my very strong, and you are not reading that subject for a quite long time, and might be you are forgetting the things. So whenever you are practicing reading, you have to work like that you have never won, that you are always making a mistake. So every time you have to correct yourself, and whenever you have to act or whenever you have to appear in the exam, you have to appear with such a confidence that I have never lost any battle, I have never made a mistake in any of the question in my previous sessions, so I'll be making all my questions correct. Okay, so you have to practice like that you have never won, that you should try to learn each and every point from the given question, and whenever you are appearing in the exam, then you have to appear with the full confidence like that you have never made a mistake in any of the question in the past, so you are also not making any of the mistake in the exam also. Okay. Next area, again, from where very commonly question is asked is about epidemiological studies. Okay, and they ask us that we have to identify the type of study. So see this question carefully. To know association between low birth weight and maternal smoking during pregnancy, studies started on 100 delivered mothers, and smoking history were obtained from their antenatal records at the time of first prenatal visit, and then subsequently assessing till delivery and birth weight at the delivery. What type of study this is? What type of study this is? Okay. So I'm getting mixed bag of answers. Some are saying as case control, some are saying as prospective cohort also, and some are saying as retrospective cohort. But mainly there is tie between option number B and also option number C and option number D. Okay, now see the question carefully. Now, as we know that if you have to identify the type of the study, the two things you have to see. One is what is the direction. Second is when we had started the study, on whom we had started. Okay, so see, they had started the study on 100 delivered mothers. The mothers has already delivered, and their smoking history is obtained. Now, those who are going with this smoking history, they are marking as case control. But see, smoking history was obtained from their antenatal records. So suppose this is a point of the delivery. So what they had done, they had gone back to this point, and from here they are started taking the history, and history is taken from the records at the time of the first visit. And at the first visit records they are looking for whether the lady is smoker or non-smoker, and then subsequently assessing till delivery. So from this point they are again coming from the prenatal time till delivery, and at this delivery point they are assessing the birth weight, which patient is already delivered and birth weight is available. So they had started at this point, this is a point of the start, but what they had done, they had gone back to the point where they had just conceived. They had taken from the records the history, and then they came forward to the current point when they had delivered, and now they are assessing that those who are the smoker women, what is the birth weight of their baby, and those who are non-smokers, what is the birth weight of their babies. Okay, so they had started with the smoker and the non-smoker, now it is exposed and non-exposed, and then they are coming forward. So yes, it is a type of cohort, but it is not a prospective because they had gone back and then they came forward. So yes, it is a clear-cut example of your retrospective cohort study. Okay, so just try to understand, whenever we are starting a study at this point, making the two groups where the disease is present at the cases and the disease is absent as control, simply going back and taking history, it is your case control study, or sometimes you may find as a retrospective study. Mind my words, I am not saying it is retrospective cohort, because retrospective is also a synonym of case control study. So it is a backward study, retrospective study, case control study, and very important parameter to show the relationship between the disease and the risk factor, it is the odds ratio, that is AD upon BC, what we can calculate. Now, if we are starting the study at this point, when we are making the two groups where the exposed and the non-exposed, we are looking forward to a point when disease will be present. It is a forward study, that is a prospective study. When we had started, the disease is absent, risk factor is there, and we are looking for the outcome, that is the disease. It is your prospective cohort study, and the parameter what we can calculate is incidence, relative risk, attributable, and population attributable risk. Because it is a long study, expensive study, and we are having the ethical risk, we are exposing the person to the risk factors, waiting for the disease to develop, that is not ethically correct. So it's a midway between the case control and the prospective cohort, where we can calculate the incidence, we can calculate the relative risk, attributable and population attributable risk, without waiting for a long, without wasting money, without exposing our healthy person to the risk factor and waiting for the disease. This is what is a midway, is the retrospective cohort study. We are starting at this point when already the outcome is present. We are going back to the point when they were healthy, and then we are making the two groups, exposed and non-exposed, and analyzing their records, coming to the present point when already the disease is present. So final direction is forward, so we can calculate the incidence, but we are not going to wait. So this is your retrospective cohort study. So obviously these are the analytical studies, and the best analytical study is your retrospective cohort study. Now another analytical is cross-sectional, when we are doing a study at the particular point only, and the parameter calculated is prevalence. Now another is at particular point when we are taking the information from the secondary source from another data, that is your ecological study. Now another forward study, but we are starting when already the disease is present. We are giving them the new drug under trial, that is treated or not treated, or we are giving them the placebo or any of the other drug, or we are simply giving them multivitamins, and these are we're looking for the result of the drug. So these are your RCT studies. So RCT, it is again a forward study, but only difference from the prospective cohort study is that when we are starting already the disease is present, and we are dividing into the groups as it is the new drug given, or the treated, or another is which is older drug, or the placebo or drug is given. Okay. So these are the different type of important studies, and we should be knowing that what parameter is calculated by these different type of studies. coming to next question. Mother-in-law brings her pregnant daughter-in-law to sub-center for TD vaccination. The guard of that center told her to wait for 20 minutes as madam is conducting delivery, to whom he is referring as madam. Okay, so the one thing is, where that lady has come, the lady has come to sub-center. Okay, and madam is conducting delivery. So, to whom he is referring as madam. So, here the point is that who is the worker who is conducting delivery at sub-center. Now, first thing is whether the medical officer is conducting delivery at sub-center. No. So, I has already told you that when there are the multiple features are given in the one option, don't look for all the features, go one by one. Okay. So, medical officer is out because medical officer is not posted at sub-center, not conducting the delivery. Medical officer is conducting at lowest center is PSC. So, option number A and C is out. Now, coming to option number B and option number D. Okay. So, again there is tie between option number B and option number D because both are multipurpose worker female. Now, the question is that what type of this center is sub-center which is conducting the delivery, because we know that sub-centers are of the two types, that is type A and type B sub-centers. And what is the criteria to defining or differentiating? The type A sub-center, it is not having beds, so it cannot conduct the delivery. Now, here madam is conducting the delivery, so obviously this is not your type A sub-center. Now, what type of this sub-center is? It is your type B sub-center where she is conducting delivery. Okay. So, those who are answering option number D, please correct it that it is not a type A sub-center. So, we are having the sub-centers which are covering the population of 5,000, and the important workers which are posted is multipurpose worker male and the female. Now, two types of the sub-centers, the type A, non-MCS centers, no beds, so they cannot admit the patient, they cannot conduct the deliveries, and type B sub-centers which are having minimum 2 beds, they can admit the patients, they can conduct the deliveries. Medical officer is posted at PSC, which is the lowest center where they are posted, and PSC it is covering population of 30,000 in the plain area and 20,000 in hilly area, and we are again having a type A and type B PSCs. Now, depending upon the workload, if number of the deliveries are less than 20 per month, it is type A PSC, and if the deliveries are 20 or more, it is type B PSC. Then we are having specialists posted at community health center covering 1 lakh population on an average, exactly is a 1.2 lakh in plain area and 80,000 in the hilly area, but on an average is 1 lakh, where we are having the specialist. And remember that all the specialists except the ophthalmologists, they are posted at a 1 lakh population, and ophthalmologists, they are posted through a vision program and they are covering 5 lakh population. So, the low risk multigravida can be delivered at lowest center as sub-center. Now, low risk primary gravida can be delivered lowest at PSC, because we are requiring to give episiotomy that can be repaired there, and the high risk pregnancies, lowest center where they can be delivered at community health center, because here we are having the operative facilities, we are having the blood bank facilities, blood transfusion can be possible, and these are giving the second level care, but these are called as first referral units. Okay, so remember these points. We are in the practicing phase. We are doing net practice for our final day match that is to be played on 6th of July, or it is 23rd of June for NEET PG. You might be making mistakes, and I say you should make mistakes. Now, until unless you are not failing, you will not get success. Now, if you remember your childhood, जिन्होंने बाइसिकल चलाना सीखा होगा, क्या कोई ऐसा बच्चा है जो बिना गिरे साइकिल चलाना सीखा है? मैंने भी साइकिल चलाना सीखा, मैं भी गिरी, मुझे भी बहुत चोट लगी. सो अगर आप किसी चीज को पाना चाहते हैं, आप प्रैक्टिस करेंगे, फेल होंगे, लेकिन अगर आपने उस फेलियर से सीख लिया, उस फेलियर को रिपीट नहीं करा, उस मिस्टेक को रिपीट नहीं करा, आप हमेशा विनर होंगे. So always remember that if you are not doing mistake, it is not that you are superhero. Maybe something wrong. So you should make mistakes, then only you will be able to identify your mistakes. And only lesson is that you should learn from your mistakes, and you have to promise yourself that you are not going to repeat these mistakes again in future life. Okay. So if you are improving your mistakes, then mind my words that you will be getting additional 5 to 7 marks as a grace marks in your examination, and those marks will be very, very helpful in your final decision. Okay. Another very, very important area from where question is asked is Intensified Iron Plus Initiative Program or Anemia Mukt Bharat. 6-month pregnant woman going to ICDS center with her 7-year-old daughter. Both are given iron folic acid tablet by Anganwadi worker. The correct statement about their iron folic acid tablets as per given program. So here, this is the logo of the given program, that is Anemia Mukt Bharat 6x6x6 strategy what we are having, that is 6 beneficiaries, 6 interventions and 6 institutional mechanisms. Now here what they are asking is that how we are giving iron folic acid tablet. Now look at the beneficiary. The first is 6-month pregnant lady. And we know in pregnancy, what is my frequency of iron folic acid tablet? I am giving daily. Another is baby 7-year-old and a child above 5 years. Prophylactically, usually we are giving once a week. These 2 points I very easily remember, because from the 6 months till 59 months, we are giving twice in a week. Baby is 7-year-old. Okay. So again, I'm very sure about the mother. So first look at the mother. 6-month pregnant, so I'll be giving daily. So daily, this could be the answer. Mother is being given weekly, so this is out. We are giving daily, this could be in. We are giving weekly, this is out. So again I say, when these type of the choices are given where the multiple features are there, you have to smartly exclude the choices. So I had smartly excluded because I know in pregnancy we are giving daily. Okay. So my weekly, option number B and option number D is out. Now coming to what is the color what I am giving in pregnancy? It is red color. So mother is getting red color. Yes, this could be true. Mother is getting red color. So yes, both still A and C are in race. Now baby, it is given weekly. So weekly, yes, this is weekly. Yes, this is okay, correct. Now catch is what color of the tablet we are giving. Now we are giving pink color tablet. Remember the small kids, they love pink color. Okay, so pink color tablet is given to the babies from 5 to 9 years. And adolescent 10 to 19, they love blue color. So blue color tablet is for 10 to 19 years. So this is out. So the correct answer left is option number A. That is baby is being given pink color tablet weekly. Okay, and mother is being given a red color tablet daily. So have a quick look on this program that we should be knowing what are the beneficiaries, because many mix and match questions are asked from this program. The beneficiaries are not from the birth, remember, from the 0 to 6 months, absolute breastfeeding, nothing is given from outside, no prophylactic iron folic. So first group is 6 months till 59 months, then 5 to 9 years, then 10 to 19 years, then 20 to 49 years, pregnancy and the lactation. Now from 5 year onwards, we are giving them a weekly and pregnancy and lactation we are giving daily. In the small babies we are giving bi-weekly, okay? And this is in the syrup form. Each ml of the syrup, it is containing 20 milligram of elemental iron and 100 microgram of folic acid. Now 10-year onwards is the adult dose, 60 milligram elemental iron and 500 microgram of folic acid. And from 5 to 9 years it is somewhere between these two doses, 45 milligram iron and 400 microgram of folic acid. These are prophylactic doses. I'm not talking about the therapeutic doses. And in pregnancy and lactation, it is given as daily. And the color of the tablet from the 20-year onwards, it is the red color. Then 10 to 19-year, it is the blue color tablet. And in the 5 to 9 years, it is pink color tablet is there. Okay. So this is beneficiaries and interventions. What we are having, the three important interventions you have to remember, that we are giving iron, we are giving folic acid, and every 6 months we are giving them albendazole tablets. So this is about a very, very important program as Anemia Mukt Bharat program. Coming to another very important program is Vitamin A prophylaxis program, from where questions are very commonly asked. So see this question. Mother brings her 3-year baby to clinic with complaint of inability to see in darkness. On examination, doctor finds white spots and advise her to give vitamin A supplements to baby to prevent future blindness. Now calculate dose of vitamin A to these babies. Now here the question is whether I am giving the prophylactic vitamin A or therapeutic. Baby is having the symptom of night blindness, inability to see in dark. On examination, doctor finds white spots. So already baby is having vitamin A deficiency. So I have to give therapeutic doses. This is first point. Second is, how much is the age of the baby? It is 3 years. I know more than 1 year. If a weight is not mentioned, I presume that baby is growing normally. The dose will be 2 lakh international units. Now mixed bag of the answers I am getting B, C and D, all three. So we are giving 2 lakh, not the stat, that is out. And I know if it is therapeutic, I have to give 3 doses. Now there is a catch, the 3 doses when I have to give. 3 doses, 2 lakh, 0, 1 and 6 month. Now, we are not giving 0, 1 and 6 month. The 0, 1 and 6 month schedule is for hepatitis B vaccination usually. Now, we are giving loading doses in a very short time, and it is scheduled as 0, 1, 14 to 28 days. So this is the correct answer. And 2 lakh stat, then every 6 months till 5 years, no. So the best answer is option number C, that we are giving 2 lakh 3 doses on day 0, 1 and 40. Now, just a quick review or quick recap about the vitamin A prophylaxis program. Now, it's the most common cause of blindness in children is vitamin A deficiency, and it is leading to a group of disorder that what we call as xerophthalmia. And WHO grading, the primary signs are xerophthalmic grade 1A is conjunctival xerosis, 1B is white spots, the 2A is corneal dryness, corneal xerosis, the 3A it is corneal ulcer, the 3B is keratomalacia, and this is a very commonly asked image. Foamy spots are seen on conjunctiva, white spots. Secondary features could be the night blindness, xerophthalmic fundus and xerophthalmic scar. Now, first symptom of this deficiency is night blindness. The first sign is conjunctival xerosis, but it is not clinically appreciable. So, first most important clinical sign for screening what we are using is white spots, and the most important or the most sensitive screening test is serum retinol level. When we can say it's a major public health problem, when a prevalence of blindness, night blindness is more than 1%, white spots are more than 0.5%, and very important, another is the serum retinol level less than 10 microgram per ml is more than 5% population. Now, prophylactically, we know that we are giving 9 doses, total 17 lakh international units, and if it is the deficiency, then 3 doses, and how much we have to give, this depends upon age of the baby. Now 0 to 6 months, it is 50,000 international unit per dose. Now remember, prophylactically we are not giving less than 9 months, but if deficiency happens, then at any age we can give vitamin A. So 0 to 6 months, it is 50,000 international units per dose. 6 to 12 months, it is 1 lakh international unit per dose. More than 1 year, and if a baby is 8 kg plus, it is 2 lakh international unit per dose, and if it is more than 1 year with less than 8 kg, it is 1 lakh international unit per dose. So this is about our vitamin A prophylaxis program, very important area from where questions are commonly asked. Yes, our journey is quite tough. You might be having turbulence in your mind. Sometimes you doubt your capacity, your capability, that whether I will be able to achieve success, whether I will be perform well in the upcoming examination, whether I will be able to remember what I am reading in the examination hall. So keep yourself calm and cool, because if your brain is calm, quiet, then only you can be having the best performance, because the ultimate weapon against your battle is your cool mind. So whenever you are in doubt, whenever you are in dilemma, confusion, just relax for a while, again recharge your battery, give some rest to your brain, and again start revising the things. Identify vector responsible for disease causing lymphatic obstruction. Vector breeding in dirty water but can fly up to 11 kilometers. So here the 3-4 hints are there. First we have to identify the disease, and they had already given a hint that what is this vector is. So vector which is responsible for disease causing the lymphatic obstruction. So lymphatic obstruction is in filariasis. Now filariasis, we know it is caused by a vector. That is which vector? It is your Culex, which is breeding in the dirty water, because Aedes are breeding in artificial water collection. Anopheles are breeding in fresh water, and this can fly up to 11 kilometers, because Aedes can fly up to 100 meters and Anopheles can fly up to 3 to 5 kilometers. So I know that they are talking about the lymphatic filariasis and the vector is Culex. Now we have to identify which one is Culex mosquito from given choices. Okay, so if I say this is my option number A, this is my option number B, this is my option number C, and option number D. And yes, you all are answering quite correct. Now first of all, we have to see the sitting position. Now sitting position, Anopheles is sitting an angle, A and Anopheles angle. So this is sitting with an angle to the surface. So this is your Anopheles. If it is sitting parallel, it may be Culex or Aedes. Aedes, A, E, D, D for dots. So if the dots are present on the body, it is your Aedes mosquito. Okay. If it is sitting parallel without any dots, it is your Culex. Okay. So yes, the correct answer for this is Culex, and this is fly, which is having oval wings with the cilia, and this is your scent fly, and this is causing leishmaniasis. Okay, so the Culex, it is causing what disease? It is leading to filariasis. Japanese encephalitis, two very important disease. The Aedes, it is causing your dengue fever, chikungunya, yellow fever, Zika virus disease, and Anopheles, it is causing malaria. These are certain images of some of the vectors, and we should be knowing some of the diseases caused by this. This is louse, which is causing epidemic typhus, flea, endemic typhus, and plague. But remember, if they ask is pneumonic plague, no vector. And this is your mite, which is causing scrub typhus, and these are the 4 mosquitoes what we had already talked about. This is again scent flea, which is causing COSO, that is Kala-Azar, leishmaniasis, oriental sore, sandfly fever and the Oriya fever, and these are the soft tick and hard tick. We know that a soft tick, it is causing KFD outside India, but in India it is caused by hard tick. And one very important disease is again the Q fever. Q fever, the first answer is that no vector is required because it is transmitted by the aerosol route, but if still vector is required, then it is your soft tick. So these are some of the important vectors and their respected diseases. In a group of 500 persons with mean blood sugar of 110 mg/%, with standard deviation of 10 mg/%, which statement is correct? Again, this is a very important area from the statistic from where question is asked. So look at the keywords. What is the mean blood sugar? It is 110 mg/%, standard deviation of 10 mg/%. Okay. Now 68% is, it is the value of plus minus of 1 SD. And what will be the range is 10 milligram less, 10 milligram more. So it is 100 to 120 mg/%. So they are asking what is the correct statement. So yes, it is the true statement, because 68% plus minus of the 1 SD, it is 100 to 120 mg/%. 95%, it is plus minus of the 2 standard deviation. It is having the blood sugar range of 90, it is yes, it is minus 2 SD, but 120 it is not, it is your plus 1 only. So correct should be 90 to 130. That should be the correct range. So this is your false statement. Okay. 68% has the blood sugar range. So again, the 68% is what? Plus minus of the 1 SD. It is having the blood sugar range as 90. It is minus 2. 130, it is plus 2. So ideally, the 68% range should be, it is 100 to 120. That should be the correct range. So this is also wrong. Now 95%, again, this is the value of plus minus of 2 SD, and it is 100 is minus 1, 130 it is plus 2. So ideal range should be 90 to, it is 130. So again, this is your wrong statement. So you all are answering quite correct. So the correct answer to this is option number A, that is 68% blood sugar percentage have a blood sugar range of 100 to 120 mg/%. So have a quick look on our normal distribution pattern of the Gaussian curve. We know it is bilaterally symmetrical, and when the distribution is like this, the mean, median and mode are same, in contrast to a right skewed deviation where the mean is maximum and followed by median and the mode, and the left skewed or the negative skewed deviation, the mode is maximum followed by median and the mean. Now within plus minus of the 1 standard deviation, it is 68%, the best will be 68.3%, and within plus minus of 2 standard deviation is 95.4 or 95%, and within plus minus of the 3 it is 99.7% population is coming. So see the percentage they are giving, or they are giving the standard deviation and they are asking you the range, or sometimes they can give you the range and they can ask you the standard deviation, or they can ask you how much a percentage of the population is within that. Now sometimes they are making the question little bit tricky and they are asking that how much population is outside. Okay, so if they ask that how much is the population outside this plus minus of 1 SD, it is 68% inside, so 32% is outside. The 16% is above plus a 1 and 16% is below minus 1. Now 95% is within plus minus of the 2 standard deviation. How much is outside? 5%. Now it is 2.5% is above plus 2 standard deviation and 2.5% is below minus 2 standard deviation. So see the question carefully. They are asking inside or they are asking outside. You are working quite hard. Sometimes you might be having turbulence in this journey, which may irritate you. But as I said, that your patience level is very, very important. because to get the best in your life, sometime you have to face the worst situation. So how you are able to handle that worst situation will be deciding your future. So just imagine that you are passing through your worst phase for only few more days to get best in your life. An individual reports with a large wound from dog bite which is bleeding, who had received the full course of anti-rabies vaccination 2 months back. So here the one question, that what is the grade of the bite? It is the large wound with bleeding. So it is your grade 3 bite, one thing. Second is, who had received the full course of the anti-rabies vaccination 2 months back. Now consider following option. We have to choose what is correct one. Anti-rabies vaccination intramuscular. So before going for the choices, now make an answer in your mind. I know that if a person had received the full course within past 3 months, then no vaccine or immunoglobulin is required. Although having a grade 3 bite, so I might think that I have to give the vaccine and immunoglobulin both. But as already had received the 2 months back, so till 3 months, nothing is required. 3 months to 2 years, we have to give a booster doses of the vaccine. And if it is more than 2 years back, then I have to give the full course. Now here it is the 2 months back. So will I require to give the anti-rabies vaccine? No, I will not give the anti-rabies vaccine. Anti-rabies vaccine intramuscular, the schedule is 03, means they are asking about me that booster doses can I give? No, again because I received only the 2 months back. Now clean the wound for 15 minutes with soap and water. Clean the wound for 15 minutes with soap and water. Yes, it is the true statement. I have to clean the wound because it is a large wound with bleeding. Now give equine rabies immunoglobulin dose. It is 40 international units per kg. Again, within 2 months back, he had received the full course, so it is not required. So again, this is a false statement. Do immediate proper wound suturing. Large wound, will I do immediate suturing? No. For at least minimum 24 hours, I will not be giving the suturing. Okay, so this is also my wrong statement. So only my correct answer is, that is, I have to clean the wound for 15 minutes with soap and water. So yes, many of you are answering quite correct. Little bit a lengthy question, little bit a tricky question, but if you know the correct answer in your mind, then definitely you can go with correct choice. And here the answer is option number D, that is 3 only, means I have to only clean the wound, not I will be giving the suturing, not I'll be giving any vaccine or immunoglobulin. So quickly, we will be revising that what is the schedule for rabies vaccination. So see the word very carefully. They are asking as a pre-exposure prophylaxis or the post-exposure prophylaxis. Now pre-exposure before the dog bite, we are giving as 0, 7, 21 or 28. These are the doses which are given on these days by intramuscular route. Now post-exposure prophylaxis, if it is already vaccinated or received the vaccine earlier after bite, that within 3 months the no action or no vaccine or immunoglobulin is needed, only we have to give the local care. Then 3 months to 2 years we have to give the booster doses, and that booster dose is 0.3 if it is given via intramuscular route, and intradermal, the best is what we say is a 4 site on the day 0, the 2 deltoid and 2 lateral thigh, and now we are giving on a 2 site on the day 0 and day 3 also. Now non-vaccinated SN regime, it is intramuscular regime what we are giving on a day 0, 3, 7, 14 and 28, and Thai Red Cross where we are giving the 4 site, that is 4 days may we are giving on a 2 sites, that is 22202, and here this is number is representing the site and the root is intradermal, and intradermal is usually preferred over intramuscular because it is having better antibody production. So now we can have the loading a higher dose with the 2 ampules intramuscular on the day 0, that is what is Jagreb regime, it is written as 20101, and here the number is representing how many vials we are giving. So this is all about our schedule, and if we are giving immunoglobulins, if it is human immunoglobulin, it is 20 international units per kg, the total dose, and if it is equine immunoglobulin, it is 40 international units per kg of the body weight. Always remember the total dose should be diluted and equally given on multiple wound site. Okay, so this is all about our rabies prophylaxis. Another very important area is malaria and its related program. So, incorrect statement about malaria are all except. Chloroquine is drug of choice for falciparum malaria in first trimester. So, chloroquine, it is not the drug of choice for falciparum. What is the drug of choice? It is the quinine is the drug of choice in first trimester. So, this is your wrong statement. Now, artesunate therapy is given for falciparum malaria in first trimester. Now, in first trimester, the artesunate therapy, it is contraindicated. The quinine is only the drug of choice. So, it is again your wrong statement. Okay, so they are asking incorrect statement about malaria are all except, means they want to know the correct statement. The quinine given for falciparum malaria in first trimester of pregnancy in all the states, yes, it is the true statement, and quinine is given for falciparum malaria in first trimester pregnancy in northeast states only. No, it is in all the states. Okay, so this is a false statement. So yes, you all are answering quite correct, and here the correct statement, because they are asking all are incorrect except, means they are asking the true statement. So again, I just want to emphasize here that don't make silly mistakes, that see the question whether they are asking the incorrect statement or they are asking a true statement. So all are incorrect about malaria except, means they are asking the true statement or the correct statement, and only the one statement is correct here, is that is option number C. We know you all are working very hard. So always remember one thing, that God is looking at you. If you're working hard, then He will not disappoint you. You just focus on your karmas and let everything on God. Just focus on your hard work, and if you're working hard, definitely you're going to get success in your upcoming examination. In this journey, you cannot avoid hurdles. The firing will be there. You have to face hurdles. You cannot run from that journey. Now you have to move further. So what you have to do? You have to make yourself stronger to face all these hurdles and continue your journey, and you will be definitely reaching to end point, and that is success. Two-year-old child reported to PSC whose mother is a known case of HIV, but baby is HIV negative. So very important keyword, the age of the baby is 2 years. Although the mother is positive, but the baby is HIV negative. With complaints of fever and breathlessness, on examination by multipurpose worker male, it was reported that respiratory rate is 55 per minute. This is another catch. So for a 2-year baby, is it normal or abnormal? It is abnormal. Less than 40, beyond 1 year is normal. But if it is 55, then it is high respiratory rate. So definitely baby is having fever, breathlessness, high respiratory rate. So baby is having pneumonia. with presence of chest indrawing, some hypoxia is also there. Now, management protocol under IMNCI program. So, first of all, you have to categorize that this will be coming in which grade, no pneumonia, pneumonia, or severe or very severe pneumonia. Again, I am getting mixed bag of response B, C or D. Now, first of all, just compile these keywords. 2-year baby with high respiratory rate with chest indrawing. Now, as we all know, now this classification is updated. Earlier, we were including the children with the chest indrawing as severe pneumonia, and we were making the immediate referral. But now, if a baby is HIV negative, more than 2-month baby with chest indrawing will be included in yellow category. So we are having the 3 categories. The no pneumonia is green category, which is home-based treatment we are giving. Now, yellow category is more than 2-month baby with chest indrawing, high respiratory rate, or that babies without HIV will included in the pneumonia, okay? And who are included in severe pneumonia, more than 2-month baby with chest indrawing if HIV is present, or any baby between 0 to 2 months may be HIV negative, but it is a severe pneumonia that is included in not the red category, that is a pink category, and we are giving pre-referral medication and doing their referral. Okay, so here the first thing is that this baby is yellow category. Okay, so this is your yellow category number 1. So green is out, red is out, pink is out. Okay, so yes, you all are answering very correct. That is yellow category. We are giving antibiotic and doing the follow. So a quick recap of this classification of the pneumonia. Now, if respiratory rate is normal, it is no pneumonia. If it is increased, it is pneumonia or the severe pneumonia. Now, upper respiratory tract symptom will be seen in all. Accessory respiratory muscles, if they are present in the pneumonia with the baby more than 2 months without HIV, will be yellow category pneumonia. But if it is 0 to 1 baby, or more than 2 months with HIV with accessory muscles, it is severe or very severe pneumonia. And feature of shock will be definitely present in the severe or very severe. Now, it is pink category, pre-referral antibiotics and immediate referral. Antibiotic and follow-up in the yellow category, and the home-based treatment is in the green category. You are treating a patient of leprosy with given MDT pack. MDT is multi-drug treatment or multi-drug therapy pack. Correct statement for treatment is. Now we know that this pack is we are using in leprosy. Now the government of India has accepted to use this 3-drug treatment for both posse and multibacillary leprosy cases. Earlier we were using only for multibacillary, although for the posse bacillary it will be starting from next year, but it has accepted the WHO guidelines. Now what these 3 drugs are? The clofazimine once a month, rifampicin and dapsone daily. No, we are giving rifampicin once a month. So this is your wrong statement. Rifampicin once a month, clofazimine and dapsone daily in the same dose. Again, clofazimine and dapsone, we are not giving in the same dose, because what we are doing in clofazimine, that we are giving the loading heavy dose as 300 microgram once a month supervised, and then 300 milligram and then 50 milligram daily we are giving, so it is not in the same dose. So this is also your wrong statement. Rifampicin once a month, clofazimine once a month in a higher dose than smaller doses daily, and dapsone daily in the same dose. Yes, this is the correct statement. So beta G's, those who are answering the option number B, see very carefully that clofazimine and the dapsone we are not giving daily in the same doses. We are having the heavy loading dose once a month for clofazimine, and then the smaller doses we are giving daily. Okay, and clofazimine, rifampicin and the dapsone we are giving all once a month. No, it is also a wrong statement. So here the correct option is option number C. Okay, so have a look on this pack, which is again a very important. Now here this is the first day therapy. We are calling the patient, and under supervision we are giving these 2 capsules, 300 milligram each, total 600 milligram of rifampicin. These 3 capsules, 100 milligram each, total 300 milligram of clofazimine, and the 1 white tablet of the dapsone. This is given day 1 under supervision, and then we are handing this back, and this is the combo what person is taking daily, and this white tablet is 100 milligram dapsone, and this black color tablet, brownish blackish, is your 50 milligram of clofazimine person is taking daily, and every month this pack is repeated. So this is repeated for a total about 6 months in the paucibacillary, and the 12 month we are giving in multibacillary. And how we are differentiating whether this is a pauci or the multibacillary leprosy, depending upon the skin lesion. If it is 1 to 5, it is pauci. Num is pauci, means less, and more than 5 it is multibacillary. Now it is 0 to 1 is affected, or if it is more than 1 is affected, it is multibacillary. Okay, and we are calling the person for follow-up. In the paucibacillary, we are calling that person is yearly for 2 years, and in the multibacillary yearly for 5 years. And during this follow-up period, if no relapse is seen, then the person name is removed from a register. So this treatment is very important under our program. And remember, this program is National Leprosy Eradication Program. It is not a National Leprosy Elimination Program. Now the important success mantra is you always have to dream big. You have to work hard and stay focused on your goal. Now, if you are focusing yourself on your goal, working hard with a big dream, with open eyes, definitely you are going to get success in your life. A 40-year patient with acute cholecystitis with HIV, hepatitis B and hepatitis C negative. A report has undergone cholecystectomy operation. Now there was massive bleeding during surgery, and at the end 500 ml of blood was in suction bottle. Disposal of this blood. Disposal of this blood. Now first thing is, what is this category? Now this is the liquid chemical waste. It is in yellow category. Second important point is, so this is yellow category, yellow category, yellow category, yellow. Okay, so all are in field. Do we require to do disinfection before the disposal of this liquid chemical waste? As we all know that yellow content, they don't require the disinfection, but we had already discussed that 2 categories of the yellow waste require the disinfection before the disposal is microbiological waste and liquid chemical waste. So this blood is liquid chemical waste. Although it is negative, but still we have to do disinfection. So no disinfection, this is out, this is out. So now we are left with 2 choices that we have to do disinfection. Now, all the content of the yellow category is usually discarded by incineration, except the liquid chemical waste, which are not requiring any collection bag, and they are discarded in the drain. Okay, so please correct your answer, beta. Now the 3-4 points here. The category of this is yellow because it is liquid chemical waste. We are requiring the disinfection in this, but we are not disposing just like a other routine yellow category by incineration. Okay, so the best answer is, it is option number C, that is yellow category. This is coming, and we are doing the disinfection and discarding in the domestic drain. Okay, so quickly, there are the 4 categories. The yellow, it is pila for pus, means all the type of infectious non-recyclable waste. Red, lal lachila plastic, it is all infectious recyclable plastic waste. Coming to white, it is sharp infectious recyclable waste. And blue, what we are having is the infectious recyclable glass items or removed body implants. Now, if it is non-infectious waste, that is plus covering of all our syringes, gloves, Foleys, catheters, Eurobag, it is non-infectious, so they are going in the black category, or it is simple municipal domestic waste. Okay. Now, yellow category, mainly we are not doing disinfection, discarding by the incineration, but for red, white and the blue, the first is disinfection, then shredding and mutilation, and then final their disposal. So remember these points about biomedical waste disposal. A person with 6/60 vision in right eye and less than 1/60 in left eye, type of blindness. So the right eye is 6/60 and the left eye is less than 1/60. Now first we have to see which is better eye. Obviously the better eye is right eye. And we know, as per the old guideline, if it is less than 6/60, it was called as blindness. But in the current definition, because India has adopted the WHO guideline, if it is less than 3/60, it is blindness. If we go with the older guideline, economic blindness means if a vision is less than 6/60 to 3/60, vision less than 6/60 to 3/60, it is your economic blindness. What is social blindness? If it is less than 3/60 to 1/60, it is your social blindness. What is the manifest blindness? If it is less than 1/60 to perception of light present, it is manifest blindness. What is the low vision? Low vision is if it is less than 6/18 to 6/60. Now here the better eye is right eye, the vision is 6/60. Okay, so it will be coming in this range, less than 6/18 to 6/60. So no beta ji, it is not an answer as option A or option B. It is the low vision, because they are not saying less than 6/60. Now please be very careful, see whether they are saying 6/60 or less than 6/60. If it is less than 6/60, then you might be coming in the economic blindness, but here it is 6/60, so it is your low vision. So this is how we will be classifying as per the old classification, that vision 6/6 to 6/18 is normal vision. The less than 6/18 to 6/60, it is the low vision. So this is the right vision, right eye vision. Okay, less than 6/60 to 3/60 is economic blindness. Less than 3/60 to 1/60 is social blindness. Less than 1/60 to perception of light is manifest blindness. While in the new guidelines, it is any value less than 3/60 is blindness, and above is the 2 slots. Mild visual impairment is same as the low vision. Severe visual impairment is same as economic blindness. Okay, so be very careful. Okay, so this is what is answer is low vision. Now every time you're getting up in morning, you're having a plan in your mind. And in the end, if you had fulfilled your plan, you are feeling relaxed. So always make a solid plan in the morning. Try to complete your plan and sleep with feeling of satisfaction that yes, I had achieved this small targets. I had completed my plan for today, and you feel satisfied, you feel happy, and you should be giving compliment to yourself that yes, you are able to achieve your today's goal. Management following severe crush wound in a 23-year-old boy who is having complete vaccination as per universal immunization program. Now, what to do? Now here, the key word is that severe crush wound, one thing. Second is, the age of the baby is 23-year-old boy who is having the complete vaccination as per the universal immunization program. Now first you have to think that as per the universal immunization program, when he had received the past vaccination, he had received the past TD when he was 16-year-old. This is as per our normal program. So he had received the TD vaccine at age of 16 and current age is 23. So he had received 7 years back. So he had received 7 years back. Okay. And yes, you all are answering quite correct that if he had received within past 5 years, then no action is required. So this will be if he had received within past 5 years. Okay. Single dose of TT, if he had received within 5 to 10 years, yes, he had received 7 years back. So yes, this is the correct answer. Single dose of the TT with tetanus immunoglobulin, no, it is not required because although it's a severe crush wound, but he had received within past 7 years the vaccination. If he had received this dose more than 10 years back, in that case, we will be requiring the TT and immunoglobulins. So it is also out. And full course of the TT vaccine with tetanus immunoglobulin, no, full course is not required because already he had received the TT vaccination earlier. So right now only we are giving the TT vaccine. So here the correct answer is single dose of TT injection. So quickly, just have a look for prophylaxis following injury. If it is a minor wound, what are the wounds which are minor? Clean wound less than 6 hour duration, non-penetrating and the negligible tissue damage, and rest all other are major category wounds. Depending upon the immunization status, if the booster and the any dose is received within 5 years, then no action will be needed in these two categories. But if it is within 5 to 10 years, the TT injection in both the categories, more than 10 years back, in the mild category, the single TT injection, and in the severe category, the TT and immunoglobulins we have to give. And if the person is non-immunized, then the single TT in minor injuries, the TT with immunoglobulins to deal immediately, and then we have to give complete course of tetanus vaccination. Incorrect about action taken to prevent mother to child transmission of infection in given program. So this program logo is what? This is a program of the branch of the National AIDS Control Program, and this is PPTCT, Prevention from Parents to Child Transmission. Okay. Now in this program, what is an incorrect about the action? So they are talking about incorrect to prevent mother to child transmission. Now give ART to mother as soon as on the diagnosis and continue throughout pregnancy. So this is true statement. Now we have to give the ART to the mother as soon as on diagnosis. Okay, it is not depending upon CD4 count. Newborn prophylaxis with nevirapine for minimum 6 weeks. Yes, we are giving, if mother is taking ART, then we are giving nevirapine for minimum 6 weeks. This is also a true statement. Single dose nevirapine to mother at the time of labor and newborn just after the delivery. Now this is your false statement because earlier we were giving this single dose, but now we are not giving the single dose. Okay, so this is false statement. And HIV positive mother can deliver HIV negative baby, as with the proper intervention, the transmission risk is only less than 1%. So yes, very true. If you are giving an intervention to the mother and the baby prophylactically, then risk of transmission is less than 1%. So this is also true statement. So yes, you are very right. They are asking about the incorrect statement. Incorrect statement is single dose of nevirapine. So have a quick look that we are dealing here the two components. One is the mother and the baby. Now mother is maybe a known case of HIV on ART, and if she become pregnant, we have to continue the ART. There is no need to stop in the first trimester or stop throughout the pregnancy. It is safe in the first trimester. If mother is diagnosed in the antenatal care first time, we have to start ART as soon as possible, and it is not depending on the CD4 count, it is not depending on trimester of pregnancy. We have to continue throughout the pregnancy, delivery and the breastfeeding and lifelong. Now newborn prophylaxis, as baby is receiving to prevent the transmission, so it is prophylaxis or primary level prevention to be started as soon as possible with the best results within 2 hours, but maximum up to 72 hours. It depends upon the mother's state. If the mother is taking ART for more than 4 weeks before the delivery, it is sufficient intake is there. And if it is baby had not received mother has not received the nevirapine in the previous deliveries, then in that case we are giving the nevirapine only for 6 weeks to the baby. But if mother has received the nevirapine in the previous pregnancy, in that case we are giving zeravudine for 6 weeks. But if mother is not taking the ART or has taken for less than 4 weeks duration before the delivery, then we will be looking for viral copies. If it is less than 1000 copies, it means it is a low risk mother, low risk transmission, then we are giving only the nevirapine. But if the viral copies are more than 1000, it means it is a high risk mother and high risk transmission. In that case, we are giving both nevirapine and the zeravudine. If baby is on top feed, then we are giving only for 6 weeks. But India, as we are allowing the breastfeeding, so minimum we are giving for 12 weeks, can be extended up to 6 months. So this is how we are prophylactically giving ART to a baby for an HIV positive mother. Now, as we all know that we are entering in our winning month. So winning month will be month of June for those aspirants who are appearing in NEET PG exam, and winning month will be month of July for those who are appearing in FMGE exam. So just go on working hard, because now we had entered in our winning month, so nobody can stop us winning this race. And the last question of this session, 25-year lady with 10-week pregnancy is diagnosed with MDR-TB. Okay, next step in management. Now, MDR is multi-drug resistant TB. These are the category 4 cases which are resistant to rifampicin and isoniazid. Now, as we know that if it was in category 1, we can start the ATT as soon as possible on the diagnosis. But the drugs what we are using in the MDR-TB, they are not safe. So, the best option is, if MTP is possible, we should do first MTP and then start the MDT or multi-drug therapy for MDR. And if it is not possible, as per the MTP Act guidelines, so we have to give modified treatment. This we know. So here the question is, how much is she pregnant is 10 weeks. So very well, she is in the range of easily doing an MTP. So start an ATT as soon as possible. No, we are not starting because it is an MDR-TB. So it is out. Do first MTP and then give the recommended protocol. Yes, this is the best answer. Continue pregnancy with modified ATT protocol. No. If they say it is the 6-month pregnancy, or it is 7-month pregnancy where MTP is not possible, in that case, you have to follow this. So this is also a wrong statement because it is 10-week pregnancy. Wait till delivery and after delivery start the ATT. Again, this is a wrong statement. So just quickly revise the category of the tuberculosis. The category 1, these are the newly diagnosed case of pulmonary or extrapulmonary tuberculosis. The category 2, these are the relapse cases, the failure cases or the defaulter cases. Now category 3 is not existing, now it has been merged with the category 1. Now category 4 is the MDR cases which are registering to rifampicin and isoniazid. And category 5 is the extensive drug resistant XDR cases which are registering to rifampicin, isoniazid, quinolones, and the second line injectable as kanamycin and capramycin, what we are using for treatment of MDR cases. Okay, so these are the categories. And category 1 treatment, the fixed drug what we are giving 2 months, the 4 drugs HRZD. Then for next 4 months we are giving the 3 drugs. So total duration of therapy is 2 + 4, that is 6 months. Now category 2, we are looking for the rifampicin sensitivity. If they are sensitive, then we are treating as in category 1. And if they are resistant, we are treating as an MDR and XDR cases. What drugs we are giving in the MDR and XDR depending upon the drug sensitivity. Okay, and one very commonly asked question is that if it is a patient of HIV and you are suspecting a tuberculosis, so the best test for the diagnosis will be CBNAT. Okay, although in other cases we are doing first a sputum smear, but still the gold standard test is CBNAT. That in each and every case before now starting the treatment we are giving doing the CBNAT to look for rifampicin sensitivity. So beta, very important point is याद रखना जिस भी लक्ष्य को आप लगातार अपने दिमाग में रखते हैं उसे आप जरूर पा सकते हैं. So whatever the goal you are keeping in your mind and daily you are remembering, you are reminding yourself your goal, that you are definitely going to achieve that goal in your future life. Okay, so after your exam, when you look back and you will say that yes, I had made it. So you all have to work hard to make this word true, that yes, I had made it. मैंने कर लिया, मैंने एग्जाम फोड़ लिया, मैंने पास कर लिया. So definitely the day is going to come when this statement will be proving correct for you, for everyone, that yes, you had made it. So these were some of the important topics from where most commonly the questions are asked in our exam. And again I'll say, read the question very carefully. Try to see keywords without making mistake. Try to combine those keywords to come to your correct diagnosis. Be fully alert because examiner will be trapping you. Try to see the choices carefully. Try to exclude one by one. Okay? So, beta, although my voice is not too good today, and again, as I say, I'm not a professional singer, but चूंकि आप लोगों से इतना प्यार है, लगाव है, तो कभी-कभी 2-3 लाइनें गुनगुना लेते हैं, ठीक है? So, again, you all are demanding for a song. So I'll try my level best, and as you all are my friends, so we are the good friends. So this song is on the friendship. Okay, so these are the few lines which are based on our friendship. So just try to bear with me because again, as I say, I am not a very good singer. तेरे जैसा यार कहाँ, कहाँ ऐसा यार आना, तेरे जैसा यार कहाँ, कहाँ ऐसा यार आना, याद करेगी दुनिया तेरा मेरा अफसाना, याद करेगी दुनिया तेरा मेरा अफसाना। मेरी जिंदगी सवारी मुझको गले लगाकर बैठा दिया फलक पे मुझे ख्वाब से उठाकर, मेरी जिंदगी सवारी मुझको गले लगाकर बैठा दिया फलक पे मुझे ख्वाब से उठाकर, यारा तेरी यारी को मैंने तो खुदा माना, यारा तेरी यारी को मैंने तो खुदा माना, याद करेगी दुनिया तेरा मेरा अफसाना। मेरे दिल की ये दुआ है कभी दूर तू न जाना, तेरे बिना हो जीना वो दिन कभी न आए, तेरे बिना हो जीना वो दिन कभी न आए, तेरे संग जीना यहाँ तेरे संग मर जाना, याद करेगी दुनिया तेरा मेरा अफसाना, तेरा जैसा यार कहाँ, कहाँ ऐसा यार आना, याद करेगी दुनिया तेरा मेरा अफसाना। So with these words, wishing you all the good luck for your upcoming examination from entire MIST team, and we all wish from bottom of our heart that you all should get success in not in your upcoming exam but in rest of your life. Wherever you go, you will get success in your exam. So again, thanking you very much from the entire MIST team for attending this session. So I think there is not a query left. I had tried to solve all your queries in between. So with these words, I'm closing the session. Once again, thank you all.